I'm going to give you a very quick update on LAMs, particularly things that may not have been discussed much in the literature. So we know all these stents are available, the hot Axios, the Nagy stent, the Spaxus stent, and the EUS stent from Germany. The only thing that is new in this area is that the hot Axios is now available in the length of 15 millimeters. So lesions that are distant can be drained safely. Otherwise, it used to be just 1 centimeter. So what is new? I think these are the 3 areas I'm going to talk to you about. One is pancreatic fluid collection. We'll talk a little bit about algorithm, adverse events, and impact on disconnected pancreatic duct syndrome, a little bit on biliary drainage, and then finally gallbladder drainage. So one of the things to remember with the fluid collections is that placing a stent in a collection is just the very first step in management, and subsequently there are a lot of things that need to be managed. Our ultimate goal is not to just drain the collection, but to prevent long-term recurrence, because if the patient is going to have a recurrence in a few more months or years, then it really doesn't serve the purpose. So generally things are straightforward. If it is a pseudocyst, you can place either a plastic stent if money is not an issue, or if the patient is non-compliant. Otherwise, lumen opposing metal stents work very good for pseudocysts, and they should be removed in 3 to 4 weeks. But if you've got, this is a classic pseudocyst, and because there is no necrosis, any stent is going to work in this patient. If you've got somebody like this, a 40 centimeter pancreatic collection that is compressing the stomach, then obviously you go ahead and place a single gate technique with a big 15 or a 20 millimeter LAMs, and if it doesn't work very well, you can do a necrosectomy through the LAMs and so forth. You can have a fluid collection like this. They are both 10 centimeters in size, but they don't talk to each other. They are completely isolated, but the patient is very symptomatic. So these patients will require something called the multi-gate technique, where you may have to place a combination of metal plastic stents or identical stents through different tracks for better drainage because they're not communicating. Then you can have a collection like this. You got a collection where the pancreatic body and tail are preserved, and then the neck is very not viable, and you got a fluid collection there. So this is a disconnected duct syndrome. In these patients, they have to be managed differently. You can use, if it's a small collection, you can just use a LAMs, and then to drain the tail, you replace the LAMs with a plastic stent. If it is a large collection with a disconnected duct, then you can create 2 gateways, one with metal and plastic, and after a couple of weeks, you remove the metal and the plastic stent will continue to drain the tail of the pancreas. And then you can have a collection like this, where you got a huge collection adjacent to the stomach, then it tracks all the way to the lower abdomen and pelvis. This patient will not get better just with a lumen opposing stent. They require dual modality drainage, where you place a lumen opposing stent in conjunction with a percutaneous drainage catheter, preferably 14 French or larger in size for better drainage. And if nothing works, then you go for necrosectomy. Does this work? This is an algorithm that has been practiced in our group. This will be presented at DDW this year, and this manuscript is being written. About 200 patients were treated using a combination of these approaches, and all that I can tell you is that using all these approaches at a minimum follow-up of 6 months to a maximum follow-up of 5 years, the treatment success was 95%, which means the patient did not require rescue surgery, and at 6 months the fluid collection had resolved, and they were pretty much asymptomatic. 5% of the patients did not do well and require other supportive measures. So why I'm showing this slide is because all fluid collections cannot be just managed with a stent. It requires a different approach, taking into consideration long-term recurrence rates. So this was the very first report from our group, where we had a patient who came to us with a fluid collection in the pancreas. We drained it with a lumen opposing metal stent 2 days after presentation, and then the patient was discharged in 1 week. And then the patient comes back to us in about 23 days with a large hematoma, and you can see that there's a pseudoaneurysm adjacent to the lumen opposing stent. And this prompted us to make this report telling these stents should not be left indwelling and they should be taken out, and therefore the societies, particularly the EUS-guided, now recommends removal in 3 to 4 weeks' time. And here you can see that all the adverse events happen after a 3-week period, and that included buried bumper syndrome, bleeding, and a biliary stricture secondary to compression of the bile duct when the stent was placed via the duodenum. However, there is a new report that was published this month in GI Endoscopie. This is a multi-center study, primarily led from the group in Italy, where they showed that, yeah, they've got all sorts of complications that can happen. It happens 25% of the time with the lumen opposing stents. And what they tell us is that these complications don't necessarily have to happen after the 4-week time frame. It can happen anytime, and many of those complications were reported within 2 weeks. So we went back and reviewed all the 200 procedures that we had performed. And this abstract has been accepted in gut last week. And what we found is that in addition to the stents being removed in a delayed manner, maybe 3 weeks, 4 weeks, or 5 weeks. More important was the size of the fluid collection. So if there is a fluid collection that on anteroposterior diameter, not from left to right, but from top to bottom, if it is less than 7 centimeter, and then if you drain this collection, and if you leave the stent for beyond 4 weeks, these are the collections that will bleed because they tend to collapse much faster, and the stent causes friction against the regional vasculature. So therefore, indwelling lumen opposing stents in small collections may be associated with increased adverse events. This is something that we all hear about from time to time. This is called a disconnected duct syndrome. This is a report on 330 patients. And what you will find is that when you have a fluid collection in conjunction with a disconnected duct, you require more advanced interventions like a necrosectomy or a multi-gate technique or a dual modality technique. These patients will require additional re-interventions close to 30% of the time compared to patients with a normal duct, and also the need for rescue surgery, which primarily means video-assisted retroperitoneal debridement, is required in 15% of the time because they don't do as well as with patients with a preserved pancreatic duct. Therefore, in these patients whom the duct is transected or disrupted completely, we recommend that an indwelling plastic stent should be left in situ indefinitely to drain the disconnected gland. And when you do that, the rate of pancreatic fluid collection recurrence is significantly less, 18% versus 2% when the stents are removed. This is a technique, this is a video where we are demonstrating how you manage these patients. Can we play this video? So we can run this video a little fast in the interest of time. Yeah. So this is we can leave it there. This is a metal stent that is being removed. So once you remove the metal stent with a rat tooth forceps, there will be a small fistulous opening. Generally what happens is, we are also going to show you something else. Once that is removed, you can see there is the pancreatic head and the uncinate, and then as you gradually pull back, you come into a cavity in the neck region, and then you've got a viable duct upstream. So this is a disconnected duct where the duct upstream goes into the cavity from which the stent has been removed. Now what you do is there's a small opening after the lamb's removal. You want to use an ERCP cannula, coil in any guide wire. The cavity is now so small that you can probably coil just a single loop of guide wire. That's pretty much it. And then over this guide wire, we deploy a double pigtail plastic stent. Many people seem not to believe in it, so we thought we should illustrate why this is important. So after the stent was placed through the transmural tract, you will find that we are going to go with a linear array echo endoscope into the disconnected body and the tail, and then we inject a dye, and you can see that the contrast is now flowing out through the lumen. So this is the concept of a disconnected duct. If the cavity collapses, then that's when you get recurrence of fluid collection, and therefore it's very, very important. Therefore, it's very, very important to leave an indwelling stent. This again is a study that is being presented at DDW this year, where we have shown that if you don't remove the lambs and replace it with a plastic stent, the chances of recurrence is so high that compared to patients in whom no stents are placed. So if you leave a stent, recurrence rate is about 5%. If you don't leave a stent, it's about 18 to 20% of the time. And all the recurrence happens not in the short term. They happen after the 10-month period and up to a 3-year period. So if you just do a quick study, and if you remove the lambs and say, well, nothing's going to happen, up to 8 months, nothing will happen. But after a year, these patients will have a fluid collection recurrence. So this is another video that can be played. So we adopt this technique. We can run this video a little faster. Yeah. So this is a large fluid collection in the pancreas. There's a little bit of tail that is left behind. So generally what we do with these patients is to do what we call the dual modality technique. Can we run it a little faster? Yeah. So we go to the proximal collection by the antrum, and we deploy a lumen opposing metal stent. So you want to go as down as possible when you place lumen opposing stents, so that should you require a necrosectomy, it's much easier to perform a necrosectomy. So after the lumen opposing stent is deployed, you retract the echo endoscope to the proximal stomach, and then you look for the fluid collection again. And this collection, as you saw on the CT scan, is very large. Can we run the video a little faster? Yeah. So now we are on the proximal head. You've got a 19-gauge needle. You coil a guide wire, and then you deploy 2 7 French double pigtail plastic stents through this tract. We can run a little faster again towards the end. Yeah, that's reasonable. And then, there's a CRE balloon, again with the drainage of necrotic contents. and you will soon see a CT scan. Generally, in inpatients, we will repeat a CT scan in 3 days' time, looking for resolution of SIRS and sepsis in these patients, and that 72 hours, you will find that the fluid collection has completely resolved. So what we do in this case is to go back, remove the lamps, and leave the plastic stent, because if the cavity collapses, then there is no way you can drain a disconnected segment. So this is the reason you go through 2 tracks, you remove the lamps in 3 weeks, and you just let the plastic stent stay. So in my summary statement for DPDS, in patients with pancreatic fluid collections, it is important to look for a disconnected duct, and you should either replace the lamps with an indwelling plastic stent in a timely manner to minimize disease recurrence, or you adapt the multi-gate technique that I described, where you remove the lamps and just leave the plastic stents indwelling, and this will decrease a PFC recurrence. So I will now move to biliary drainage very briefly. This is some new data. The second study is from Japan, where they showed adverse events of 38% when you use lamps for biliary drainage. And that was from Bertrand Napoleon. Another study demonstrated a very low adverse event rate. But this is not a very good study. This is from the United States, looking at 40 patients with a brief follow-up of about more than 4 weeks. What they found is that in patients who had lamps, the clinical success was very low, only 50%. And all these patients required re-interventions, compared to patients in whom they placed a lamps and a double pigtail plastic stent, and they call it the axis orienting stent. So when you do that, according to them, the rate of recurrence, the rate of stent dysfunction was significantly less. And this is the concept. Even when you place a fully covered metal stent, you can see that the metal stent is against the wall of the bile duct, and it precludes adequate biliary drainage. But the minute you place a double pigtail plastic stent, the orientation of the metal stent is changed, and you got better drainage through the choledochoduodenal fistula. So probably we need to change the design of the lamps. Maybe instead of a lamps being dumbbell shaped, we probably need to have a straight end on the side that goes into the bile duct that will take the curvature towards the liver hilum, so that the stent dysfunction will be much, much less. Gallbladder drainage, I think I'm running out of time. This is a study that compared EUS-guided gallbladder drainage with percutaneous cholecystostomy, and this is a study from Hong Kong, where they showed that 1 year, the rate of morbidity was compared between the groups, and they found that EUS-guided bile duct drainage had fewer adverse events, and they also required fewer re-interventions. So the conclusion was that EUS-guided gallbladder drainage should be the procedure of choice in high-risk patients, as it reduces short and long-term adverse events, and I fully agree with them. I think there's enough data now to show that EUS is the way to go in inoperable patients for gallbladder drainage rather than percutaneous cholecystostomy. However, will lamps substitute cholecystostomy? Probably not. If you look at benign disease and if you look at all the abstracts, because failed outcomes never get published, what you will find is that a lot of food gets dislodged into the gallbladder cavity and the patient gets sepsis. So I think instead of this design, again, we need to have a change with an anti-reflux mechanism throughout the stomach, so that will prevent gallbladder. Maybe we can drain the gallbladders without the complication of food going into the gallbladder. So finally, I think lamps is a great technology. We use it for multiple indications these days. But I think we have got one problem. We are just taking one device that we have, and we are just expanding the indications over and over. But I think if we want to advance the discipline forward, although the development of lamps is pretty good, I think we need to make modifications to the design so that we can use it for different things rather than to use the same product and hope for the best outcome. Thank you.